Hi, everyone. My name is Dr. Scott Millington. I'm coming to you today from Ottawa, Canada, and I'm going to talk to you about subclavian central venous catheter insertion and whether you should do it under ultrasound guidance. I'm really happy to be here at the WinFocus World Congress 2021, at least virtually. I'm an intensivist at the Ottawa Hospital and an associate professor of medicine at the University of Ottawa, and it's a real pleasure. Now, I've only got 14 minutes, so I'm going to go relatively quickly, but I'll leave you with lots of references and my email address if you have further questions. I have nothing to disclose. And I've broken this presentation down into really two parts and two questions. So should I do it? Should I add ultrasound to my toolkit in terms of subclavian central venous catheter insertion? And if I've decided that the answer is yes, well, how exactly should I go about doing it? And the really key references here are these two that I've shown you on the screen. So Dr. Lalu, one of my colleagues at the University of Ottawa, did a systematic review and meta-analysis back in 2015, which really very thoroughly goes through the data and answers the question, should you do it? And then the how you do it question, Dr. Lalu, myself, and a couple other colleagues put out a paper in 2019 where we went through this in great detail in terms of the technique, including some videos to walk you through it. So if you'd like to see more on that end, I would refer you there. Looking first at the should you do it question and looking at this systematic review and meta-analysis, we'll get to the tables here, and you can start by looking at the incidence of failed catheterization. And you can see that in both cases, but specifically in the B box here. So the A box up top here, this is all the studies that got swept up in the meta-analysis that used some kind of ultrasound. And the B box here is the one that's more interesting to us because that's the one that approximated the technique that we're going to recommend, which is using real-time ultrasound guidance, basically watching the needle go into the vein, which is, I think, what the better technique is. And when you use that better technique, you can see that the incidence of failed catheterization is much lower with ultrasound. So, point in favor of using ultrasound. If we look at adverse events, all told, again, we can see in the A box, but even more impressively in the B box, that the incidence of overall complications is much lower when you use ultrasound. So that's good. And then finally, looking at specific complications, famously pneumothorax, arterial strike, hematoma, and hemothorax, the incidence of all four of those complications is lower with ultrasound. At least there's a trend towards it crossing one. Malposition doesn't seem to, there's a reduced incidence of all four of those. Malposition is the one that crosses one. Now, so you can imagine that, getting the catheter in the exactly right position, ultrasound doesn't help you too much there. Once you thread the catheter over the wire, well, it goes wherever the wire was. And so whether you put that wire in with ultrasound or not, doesn't really matter. So again, these four big complications seem to be lower when you use ultrasound. And so that's great. So I think, should you use ultrasound? My answer based on this would be yes. Who should do it though? This is an interesting question. And I pulled this little graphic. This is kind of, I think, an American perspective of the doctor hierarchy. So I'm in Canada. If you're elsewhere in the world, it might be slightly different, but this is not a technique that I would recommend for junior learners. So not your medical students, not your interns, not your junior residents. If you've got senior residents who are out towards the end of their training and they're on a pathway to go into a procedural-based specialty like anesthesia or intensive care where they're going to put in lots of lines, sure, under supervision, lots of supervision. If you've got your fellows, if you've got your attending physicians, obviously, provided they're well-trained, they can go ahead and do this if they want. But you're going to see that we're going to adopt, an angle of insertion that is going to make your eyebrows raise a little bit. And so you want to really be sure that the person doing this technique is very good at central venous catheter insertion in general and very good at the ultrasound guidance piece, specifically depth control. And the reason why is this is a slide I've been using for about 15 years now when I talk about ultrasound guided central venous catheters, whether it's IJ or femoral or what have you. If you look at this study done way back on mannequins, if you put a novice learner here, almost 100% of them will go too deep. They will puncture the posterior wall of the vessel and they will be too deep under ultrasound guidance for various reasons. And because the consequences of excessive depth when you're talking about a subclavian are potentially very disastrous, this is a major concern. So you want to have really perfect depth control under ultrasound guidance before you embark on this technique. Just a quick reminder of anatomy. These are some pictures from Dr. Deneau's textbook. We've got our subclavian vein, which at about the first rib transitions into actually becoming the axillary vein. And that's more commonly what you actually cannulate using this technique. And if we put the muscle back on, you'll see that we've got this nice little window of opportunity here. And if you put your hand up on your own shoulder, you can feel that recess. There's a little fossa there, which is under the clavicle and above the pec major and medial to the shoulder. There's a little window of opportunity there, which is actually where we're going to put our needle. And just pause for a moment here to remark on the position of the subclavian and axillary artery. And so if you look here, you'll see that in most people, it's cranial to the vein and deep. So remember that. The artery is cranial and deep in most cases. And we'll see that on ultrasound in a second. Another picture from Dr. Deneau's textbook here, and that's really just to remind us that depending on where you put your transducer, you're going to get a very different view of artery or vein or short axis or long axis. So we'll see this a little more in a second, but just you have to be very aware of where your transducer is on the patient's body. So questions before we begin: are we going to use a static technique where we put a mark on it and then put the ultrasound machine away and go ahead blind using our mark? That's a great technique for a thoracentesis or a paracentesis, but we're going to wholeheartedly recommend a dynamic or ultrasound guided technique where we're going to watch in real time as the needle enters into the vein. Short axis or long axis is a harder question. I really recommend short axis, but if anything, the evidence is slightly against me here. There's a couple small papers that suggest that long axis might be better. When you're doing a short axis technique, as you know from your IJs, probably, you see the vessel and you see the danger. You see the neighboring artery. And seeing the danger is particularly important for a subclavian because that pleural line is right there too, and you can see that and avoid it. However, in a short axis technique, you can go out of plane and then you're excessively deep, as we talked about, and you need to be very careful about that, okay? Long axis techniques has the advantage of watching the needle in its full length and controlling your depth very well, but you have to have very good control and you have to stay perfectly in plane to follow that needle the whole way. You have to make sure if you go out of plane, you're going to lose your needle tip, and then you may strike the neighboring structure, the artery of the pleura, without being aware. So I recommend a shorter axis technique. If you want to dabble with long axis once you get a lot of experience under your belt, feel free. So here we go. Let's do the actual procedure. We're going to start before we have our sterile field built, and we're going to take the linear transducer. We're going to put the orientation marker towards the patient's head, and we're going to sit it right on the clavicle at the midclavicular line. And what we're going to see here is this C structure. This is the clavicle, the bone which blocks ultrasound. Just towards the patient's feet here, you're going to see a little glimpse beyond the clavicle, and you can start to see a vessel here, which is probably our vein. So that's a nice start. And from there, what we're going to do is we're going to slide the transducer a little bit towards the patient's feet. We're going to get off the clavicle and it disappears out of view. And what we really start to see nicely is that subclavian vein now, marked with a V, helpfully. If we slide even a little bit further towards the patient's feet, we're going to see really the whole picture now. We see the subclavian vein. We see the subclavian artery. As I mentioned, it's cranial a little bit. The patient's head is to the left of the screen here. And it's deep to the vein. So the artery is cranial and deep, as we said before. We've got the vein there, and then we've got this very important structure, which is your pleural line. And you can really see how you get into trouble with a pneumothorax when you use a blind technique, because if you just puncture this posterior wall even a little bit, then really you're right into the pleura there. So that'll give you a healthy respect for the anatomy once you start to see this. So once we've done that, I'm now going to slide my transducer medially, so towards the patient's sternum. And what I'm trying to do is I'm trying to find a window of opportunity for a place where I can put my ultrasound transducer, and I can imagine where my needle is going to go in, which I'm simulating with my finger here. So I have a vessel that's a couple centimeters deep, and so I need to back up a little bit so I can traverse that distance. And what I'm looking for is a situation where the vein looks good on ultrasound anatomy under the transducer, and so that's your kind of your landing spot. And then your insertion spot of your needle also looks good. So I've backed up a couple centimeters from the transducer. I'm imagining going in at about a 45-degree angle. And then I've got a nice space where I'm not into the shoulder or anything like that. And I can get my needle in. And once I've done that, I'm going to just squeeze the vessel at that point and make sure there's no clot there. Make sure the vessel compresses nicely, and really double, triple check that I'm looking at the vein and not the artery. And then finally, I'm going to take a depth measurement, and this is a really important safety step. So here I can see that the vein is just about exactly 2 centimeters deep, and armed with that piece of information, I can go ahead and do some trigonometry. And if I'm recommending a 45-degree angle of insertion, it's because of this. So I've got a subclavian vein, which I've laid out in long axis here, that's about 2 centimeters deep. And so if I back up 2 centimeters, as I was doing with my finger on the left side of the screen there earlier, and if I imagine inserting my needle at a 45-degree angle, I will intersect the vein right under that previously chosen landing spot. And so this makes it all look real nice. You can do this in your head, and you can do a little bit of the Pythagorean theorem if you want to be fancy, and I can solve for x, and I can figure out that x is just about 3 centimeters. And so I know now that when I start to advance my needle, I should be expecting to get a flash of blood at 3 centimeters, let's say 3.5 to give yourself a little bit of working room. But I've got a 7-centimeter needle in my hand, and so I should not be going anywhere near the hub of the needle is the point. And so you've got a really important 3.5-centimeter stop, and if I don't have blood, there's a problem. So then I go ahead and build my sterile technique. In this case, I've got a mannequin. I get that same view with the clavicle and the vein here. I get my needle. I back up a couple centimeters. I go in at a 45-degree angle. And then what I'm going to do is I'm going to advance slowly using what I refer to as a creeping technique. And so what I'm going to do is I'm going to insert the needle by about 1 centimeter, and then I'm going to slide my ultrasound transducer towards it, and I'm going to detect the first bright structure that I see in the bottom right there, and that I know to be my needle tip. If the needle tip is heading towards the intended target, as it is here, I can advance another 5 millimeters or so, and then I'm going to sweep that ultrasound transducer way away from the needle, way past the needle, so towards the patient's sternum, and then I'm going to sweep it back, and I'm going to pick up the first bright thing that I see, and sometimes wiggling the needle can help, and then I'm really triple checking that I'm not deeper than I think I am, and if I'm still happy with my trajectory, I can keep advancing. And then by the time you do that 3 or 4 times, a couple safety checks, a couple depth checks, you'll be into the vein nice and safe. So that's the technique, and post-procedure, you can do a couple neat things. Certainly, you want to confirm that the wire is in the vein prior to dilating and nowhere near the artery. We do that anyway with all ultrasound-guided techniques. If you want to be really fancy, before you do the procedure, you can actually sterilely prep the ipsilateral neck, the contralateral neck, and the contralateral subclavian zone. And then you can look with your ultrasound transducer, and you can make sure that the wire did not go right across into the contralateral subclavian, and you can make sure that it didn't go up either of the internal jugular veins. And that avoids that frustrating, rare scenario where you put the vein or put the catheter up the patient's neck. You should check lung sliding before you start the procedure, and then check it again once you're done. And if you had lung sliding before the procedure and then you've lost it, well, you really need to be worried about a pneumothorax, and that's much faster than an x-ray. Now, make sure you do it before, because there's lots of ICU patients who don't have lung sliding, and you don't want to unnecessarily worry yourself. And then finally, you can conduct a flush test if you really want to use that catheter right away and you don't want to wait for an x-ray. Just get a view of the heart with a cardiac probe. Usually a subcostal 4-chamber view is really good. And then get one of your colleagues just to shoot in 10 cc's of normal saline into the distal port of the catheter you just put in. And if you see bubbles right away in the right heart, the catheter might not be perfectly positioned, but you're pretty close and you're safe to use it. Is there anything new since 2015, since that meta-analysis? Well, a couple things, and I've just shown them here. There's a couple good review articles that endorse subclavian ultrasound guidance and give you a kind of a step-by-step technical overview. And then there's another study comparing blind to ultrasound-guided techniques, which comes down in support of using ultrasound. So if anything, the evidence has gotten a little bit stronger since the time of the meta-analysis. Well, that's really all I wanted to say. It was a quick talk. I hope it was useful to you. You've got my email there, you've got my name, and you've got my best wishes going forward. I hope you really enjoy the rest of the Congress. And yeah, thanks a lot, everyone. It was wonderful.